This is the last part of our Intrapartum Lesson 5, Labor and Birth Complications. Obstetric emergencies. Meconium-stained amniotic fluid indicates that the fetus has passed meconium prior to birth, often described as thin or thick depending on the amount of meconium present. There are three possible reasons for meconium passage prior to birth. It is a normal physiologic function that occurs with maturity or with breech presentation, or it could be a result of hypoxia-induced peristalsis and sphincter relaxation. It also could be umbilical cord compression induced vagal stimulation in mature fetuses. The major risk associated with the passage of meconium is meconium aspiration syndrome in the neonate. Meconium aspiration syndrome is a severe form of aspiration pneumonia that occurs most often in post-term infants. The syndrome most likely results from a long-standing process rather than aspiration immediately after birth. Management of the infant following birth with meconium present requires careful assessment of the infant immediately after birth. The American Academy of Pediatrics no longer recommend suctioning the perineum or tracheal suctioning after birth unless indicated by the baby's condition. You need to review the emergency box in your textbook for management of the infant with meconium-stained amniotic fluid. Shoulder dystocia. This is an uncommon obstetric emergency that increases the risk to mother and baby during vaginal birth. The head of the infant is born, but the anterior shoulder cannot pass under the pubic arch. This can be caused by a fetus that is too large or abnormalities in the maternal pelvis. Fetal injuries are caused by either asphyxia or trauma. Trauma complications are the result of trauma to the brachial plexus and phrenic nerve and fracture of the humerus or clavicle. The most serious complication is Erb's palsy, a brachial plexus injury which occurs in 10 to 20% of infants following shoulder dystocia. Maternal complications are postpartum hemorrhage and rectal injuries. To manage shoulder dystocia, the infant's shoulder must be freed from the pubic bone. Suprapubic pressure, McRoberts, and Gaskin maneuver are methods of attempting to free the shoulder. Pictures of the process of applying suprapubic pressure and McRoberts maneuver follow. In this slide, you see the nurse applying suprapubic pressure. This will help to move the fetal head into the appropriate position for birth. In this picture, you see McRoberts maneuver. Prolapsed umbilical cord. A prolapsed umbilical cord occurs when the cord lies below the presenting part of the fetus. While this can occur at any time throughout labor, it is most commonly seen immediately after the rupture of membranes. Contributing factors include a cord longer than 100 centimeters, malpresentation such as breech, transverse lie, and unengaged presenting part. Management of the prolapse cord requires prompt recognition of the problem. On assessment of the fetal heart rate via monitor, the nurse will notice variable or prolonged decelerations. The woman may be feeling something when her water broke, definitely if the cord can be seen. To manage it will require an attempt to keep the fetal head or presenting part from compressing the umbilical cord. This can be accomplished by putting a sterile gloved hand into the vagina to hold the presenting part off the cord. The woman may be put into a knee chest, modified Sims position, or Trendelenburg. If the cervix is fully dilated, a vacuum-assisted birth may be possible. Otherwise, a cesarean is likely to be performed. In this slide, you see different cord presentations. In B, you can see clearly that the umbilical cord has entered into the cervical opening. In this case, you are going to see variable decelerations because of the pressure. Every contraction, the head will put pressure on the umbilical cord. In C, it is into the vagina. The cord is into the vagina. In both of these cases, you would attempt to hold pressure up on the fetal head to get it off the cord. And D is a frank breech presentation. As you can see with this baby, the cord was easy to come out. In this slide, you see the nurse using her fingers to hold the fetal head off of the umbilical cord. In this one, you see the nurse holding the fetal sacrum off of the umbilical cord. In In this slide, you see two different positions to attempt to get the fetal head off of the umbilical cord. In D, you see the knee-chest position, where you put the woman with her head down. This attempts to get gravity to assist and get the fetal head off of the umbilical cord. The next obstetric emergency we'll discuss is rupture of the uterus. A rupture of the uterus is a complete disruption of all uterine layers. This is a rare but extremely serious obstetric complication. The most frequent cause is scarred uterus from previous cesarean births, specifically those with a classic incision. Signs and symptoms include abnormal fetal heart rate tracing, loss of fetal station, abdominal pain, and shock. Risk of ruptured uterus include multiple prior cesarean births, no previous vaginal births, induced or augmented labor, multifetal gestation, macrosomia, post-cesarean birth infection, and short interpregnancy interval. The last obstetric emergency we're going to discuss is amniotic fluid embolism, or anaphylactoid syndrome of pregnancy. This is a rare but devastating complication of pregnancy. The patient will have an acute, sudden onset of hypoxia, hypotension, cardiovascular collapse, and coagulopathy. Amniotic fluid embolism occurs during labor, birth, or within 30 minutes after birth. The presentation is similar to that of septic shock. In both conditions, a foreign substance is introduced into the circulation, resulting in disseminated intravascular coagulation, hypotension, and hypoxia. Maternal mortality is 61% or higher. Neonatal outcome is often poor. Risks for amniotic fluid embolism are advanced maternal age, minority race, placenta previa, preeclampsia, and forceps-assisted birth. Please review the emergency box in your book regarding amniotic fluid embolism. This concludes Lesson 5.